Well, welcome back. And for those of you who are just waking up across the pond in the USA and Canada and Latin America, good morning. And good afternoon to those people who are suddenly celebrating and grabbing their lunches and currying back. And good evening for those people who are still with us from later on during the day over there in Australia. My name's Andy Bleaton. I'm the director here for our communities at ECH Alliance. And today's session, to kick off this afternoon, we wanted to give you a deep dive into some of our ecosystems. Now, throughout the last few days, you would have seen a couple of slides that have shown that network of ecosystems and where we've got ecosystems not just in Europe, but in US and Canada, Latin America, and then in Australia, India, Africa, etc., etc. And one of the treats I get is to shine a light into some of those ecosystems to say, who are some of the champions you've got there? Who are some of the shining stars you've got within your ecosystems? Who are those people that if I was to turn up to in Denmark or in Portugal or in Kuopio in Finland, who do I need to speak to? Because there's so many clusters within our network that have got great depths of hundreds of companies, hundreds of organizations. So one of the challenges I sent out was to say, look, we're going to be running this session on our ecosystems for our 6th Digital Health Society Summit. Give me one of your champions because I want to showcase some of those. And today's session, we'll do a small pitch with 3 of those. We've got input from Denmark. We've got input from Finland. We've got input from Portugal. With 3 people who I think have got some fantastic solutions and services. And also, this is the important bit, opportunities, I think, for others who are on this summit to collaborate with. That's enough about me. I'm going to go into and ask my first speaker to come and speak any second now from Copenhagen, from our Health Tech Hub Copenhagen ecosystem, one of our newest ecosystems in Europe that joined us quite recently. And we're doing a lot of collaboration between them and our networks in Canada and elsewhere. But they wanted well, it took literally seconds to say, we'd like you to meet Michael Franson, who's going to talk to us today about his solution and his services, and then where you can collaborate. So Michael, the floor is yours.
Thank you very much, Andy, and thank you all for participating today. It's an honor to be here. And actually, Andy was saying our solution, but it is actually the solution of the public ward research project that I am presenting today. So I'm going to talk about deterioration detection in general wards and in hospital at home in different words, a new standard of care in lower acuity settings. So I'm not talking about the ICU, I'm talking about the normal bed wards, I'm talking about hospital at home and a new standard of care. And it all started with a public research project in Copenhagen. And this public research project has actually done research through years, the past 6 years with 20 people. Let me just advance here, hopefully. Yes. So they have actually done research on how to avoid complications in the general wards. They're both anesthesiology professors, the founders, and they were always faced with the problem that they're called in too late in the lower acuity wards for deteriorating patients. In the ICU, everything rings and dings and there's alarms all the time and there's a nurse per patient. But in the general wards, they get called too late when the patient deterioration is maybe too unnecessarily far down the line. So they set out to find a solution for this, and they got research funding on the condition that they would spin out a company if they found a solution to this problem, because it's a very generic problem that counts for every hospital basically in the world. And they did, and I'm very proud to say that I represent the commercial spin-out ward 24/7. So the problem that they were facing is that hospitalized patients very often get complications. And in fact, it's 30% of those complications are unexpected. 40% we also know are preventable. We know that from research. The big surprise to most people is that 70% of all complications, unexpected complications that happen within the care pathway, happen in the general wards. So the complications actually happen in the lower acuity wards, which is quite surprising to a lot of people. And what does it mean? Well, it means on average a 4 to 6 day prolonged stay. And we all know what that means to hospital costs. We also know it means readmissions to the ICU and even death. So what are the underlying challenges behind the problem that the two professors were trying to solve? Well, it is that neither manual monitoring by nurses in the morning and in the afternoon shift, it is simply too infrequent, as you will see in the next line here. So you do it in the morning, you do it in the afternoon, but these are patients that came from the ICU, some of them, or came from the OR, where they were monitored with sensors on them all the time. And they go from 24/7 monitoring to 2 times a day. And they go from being watched by a nurse physically to being, in some countries, in some hospitals, even in their own room without any other patients. So it's a big gap, and this is the gap they wanted to close. The obvious way to close it would be to just continue monitoring them with sensors on 24/7. But it will create alert fatigue because you get 180 alarms per patient per 24 hours. In the ICU, you have 1 nurse per patient. In the general wards, you have 10 patients for a nurse. So that's 1,800 alarms per day. Clearly, that's not going to work. So what we see actually, the outcome, let me go back a little bit, the outcome of the current standard practice, we see a very brave hospital in Denmark who has published their results to see that in a 400-bed hospital, there was 220 unexpected cardiac arrests or deaths in a year. So 220 in a 400-bed hospital, that's 0.6 cardiac arrests or deaths per year. When you look behind that, 81% of those were not monitored according to protocol. So only 19% were monitored according to protocol. And it's not because they don't have any good nurses. It's because they don't have enough. And that's a worldwide problem. The nurse shortage is what the professors wanted to solve. So the problem, the solution that they came up with is an algorithm-based software that interprets complex vital signs patterns so into clinically relevant alerts. So instead of having monitors beeping all the time, these algorithms look at the duration of the deviations in vital signs and the combinations of them and find out which of those have a clinical relevance in terms of a deteriorating patient. And that means in the long run, so the past 6 years, they've done 2,300 observational patients, 10 PhDs, 12 million monitoring minutes annotated against short-term and long-term complications manually and published 2 large randomized control trials. The results, and that is what I get to present to the world and to hopefully get spread out to as many hospitals as possible, is that we can reduce with those results the number of alerts per patient per day to 5, to a handful. 42 is where you can get if you have the news thresholds, 180 if you don't have any thresholds. So imagine 5 a day and only the clinically relevant ones. And what it means in terms of results to patients, it's a reduction in severe adverse events of between 17 and 34%, depending on the patient population researched. And it's a 10-minute saving per patient per day. So just to sum up quickly, it reduces hospital costs, it reduces complications, and it even saves time. And that's a really important factor in the nurse shortage days. And what it looks like here, it's simply an app that takes all of the input from sensors. It it looks at the duration of the deviations of different vital signs, the combinations of them, and then it alarms only if there's a clinical relevance to that, if it's going to lead to a patient deteriorating. Fever in itself may not be, blood pressure in itself might not be relevant, but the combination and a certain duration might be relevant. So it always looks into research to see if the current set of deviating vital signs have a clinical relevance or not. And that is actually, this is the app. This is what the nurses see. This is what doctors will see if they have the app as well. And this is a common language used. Now there's a desaturation situation. They can both look at the same data and find out what to do if the nurse doesn't know. Then the doctor can say, well, I can see, in this case, you see down here, a desaturation alert. And you see you can attend, you can silence the alert, or you can forward the alert depending on the severity. And you can even document the vital signs in the app without doing these manual vital sign rounds that nurses normally do twice a day. I'm not sure about timing, Andy, but
that's good. We're good to go now. So that's really clear, Michael. So if there's any last comments, Ben, and then we can move on. Any last comments, Michael?
No, not really. Not really. Just honored to be
very clear.
Listening.
Very, very clear. Again, I always look at it in a very simple way. What was the itch and what's the scratch that you provided for that itch? So I think that's very clear there. We've seen that in that very, very clearly clear to see app that you've got there as an end result. So brilliant explanation of both need and solution. Okay, let's jump on a plane quickly and fly to Finland, to Kuopio. And I'm very, very pleased again to introduce another star from one of our other ecosystems in Finland, from Kuopio, one of 6 of our Finnish ecosystems that we have in Finland. Very, very large network. And Erkki, tell us about you, and tell us about that itch and what the scratch was that you provided.
Thank you. It's a great pleasure to be here, and thank you for this. So my name is Erkki Soini, and I come from Kuopio, Finland, and my profession is in health economics. So maybe my speech will have some health economic connotations there. Currently, I work as a CEO of ECRO, and I'm also the chairman of the board at Kuopio Health, which is an open innovation ecosystem. Among other, at the Kuopio Health, there is a health data working group where novel methods and ideas are presented and extensively discussed. We have regular meetings there. ECRO itself creates value with evidence of costs and health outcomes. And by the way, do I have the presentation here?
Yeah, the presentation's visible now. We can see your slide.
Okay, that's good. So, okay, because for me, it is not showing that.
No.
Okay.
Yeah, we can see it. It's fine.
Okay, very good. So we provide services and solutions for industry, social and healthcare, and academia. And ECR is also a member of Kuopio Health, naturally. And Whale AI and Productivity Leap are examples of few companies we collaborate there with. So we provide a full stack data use and also the evidence creation services there. My 4 pillars on the talk here are: only effectiveness or equity is worth paying for. Do not fix it if it works. Problems are vast, but can be solved with the predictions of cost effectiveness and preventive actions. And the cost effectiveness here means reasonable cost of health benefit created. Fourth, public and private partnerships and ecosystems are very much needed. By the way, I wonder, did you know that the healthcare industry generates about 1/3 of the world's data? There is about 10 zettabytes of sensitive healthcare data available. It is about 192 million times more data than the ChatGPT-4's training dataset was. And around 20% of that sensitive data is relevant for decision making. Still, only a very small fraction, like 1 or 2% of that data is used in the decisions. In addition to unused health data, societies face challenges. Among others, only 1/4 of the people are healthy, 1/3 are at increased risk of a disease event, and 1/10 have high risk for event. And the real costs are estimated to increase by 70% in next 10 years. So what to do and how? I think the clever use of data and evidence is really needed. So who should we treat and when? Well, predictive, that is a future-oriented health economic modeling and decision-making is needed. But what then? Well, insights and evaluations of value are needed. These all can be obtained with only RDIE, that is research, development, innovation, and education. These are the themes of clinical trials and real-life studies. Studies with implementation can return huge amounts of value to society. €1 invested can create €4 in value, a result from our study. Clever implementation and assessment of impact are needed for the improvements of effectiveness and cost-effectiveness, which are crucial for the survival of well-being societies. Cost-effectiveness has been demonstrated to improve with, for example, remote monitoring system, digital patient pathways, and many novel drug treatments. Improved cost-effectiveness can result in capacity freed, which is important when we are lacking person resources. Next slide, please. So, if we think about the solution, real-world data, RWD, and the cultured product of it, real-world evidence, RWE, drive healthcare innovation and transformation. But how to get the RWE? What is the solution? We must address the paramount importance of securing this treasure trove of sensitive social and healthcare data. In Finland and in the European health data space, audited and certified secure processing environments, SPEs, are needed. Spesier is an independent, highly secure computing environment in a private cloud with hybrid Windows and Linux virtual machine possibilities. It meets Finnish and non-European health data space requirements. Spesier was developed because our needs were not fulfilled with the existing systems. It is available both as platform as a service PaaS solution or together with vast expert services. Spesier has been used to create RWE from various RWD sources, such as national registers, hospital data lakes, chart reviews, text with natural language processing, quality registers, biobank data, and patient-reported outcomes. It has a data collection system inside. It doesn't require a fixed IP address, and we have actually a customer support and ticketing systems. The access management of Spesier includes strong authentication in the Nordic countries and multi-factor authentication anywhere else. The compound annual growth rate of this business is 23%, and we have very experienced and highly referenced team behind it. However, this Spesier is not just the fortress of RWD. It is a launchpad for health economic and RWD studies that support improved effectiveness and cost-effectiveness, innovation, scalability, market access, knowledge management, value-based healthcare, and risk sharing. As examples from cardiology, we have demonstrated how well pulmonary arterial hypertension PAH patients are in specialist care and what minor pitfalls are. There is not much improvement needed there. However, more common cardiovascular diseases cost around €640 per year for everything, which was recently discussed in Finnish morning TV broadcast. With improved compliance in the secondary prevention of cardiovascular diseases, around 2/3 of this money would be saved. It is a huge amount of money. For example, a digital weight loss intervention was cost-effective in a relatively short time frame and could address significant proportion of the cardiovascular challenge. If put together with the efficient salt intake, cholesterol, and blood pressure management, we should have similar results as with the PAH patients, not much improvement needed. And as a collateral damage, prevalence of type 2 diabetes would decrease. As summary, first, I think high security measures are needed for the use of data and solutions for it, such as PCR already exist. Second, good RVE is needed for the treatment of patients and decision making. Much needed cost effectiveness is doable and has been done especially for pharmaceuticals, but we need it more elsewhere too. Third, we need to discuss about the societal values. For example, there has been discussion when can we let individual to die well. Quality of life should be more on the table. The opportunity cost of giving all treatment to everyone is too much. We would run out of resources here. And the last, efficient digital solutions should be implemented much more. Okay, so let's make informed decisions together. We are happy to discuss more and collaborate. Thank you for your time.
Thank you for that, Erkku. Fabulous slides. I like that. Very, very, very clear slides. Easy to see why Finland is one of those go-to countries in terms of looking for new solutions. However, I'm sure Portugal have got something to say about that. Ricardo, the floor is yours.
Okay, thank you. First of all, again, thank you for the invitation. And I'm going to try to explain you what we are doing at Hopvens, and in particular the challenges that we are facing, which are somehow related with the previous presentation. So it helps me a little bit to explain what we are doing. So in digital health, as you probably already know, have these difficulties, these problems related with the sensitivity of the information. And so protecting this data, although it is very valuable, the health information is at the same time very sensitive. Both are related. And so data privacy and security is really an issue. And the amount of regulatory standards that we need to tackle with is increasing. And although GDPR and now NIS2 is an issue in many different European institutions, we are now also facing this new European health data space regulation that somehow tries to promote the use of data, especially in the secondary use of data. And so we have a force trying to promote privacy and security, and another force somehow on the other direction, trying to promote the reuse of data. So this is the problem that we want to engage in Hopvens. At the same time, we have another issue, is that inside health institutions where this valuable data exists, this data exists in many different systems. And typically, this is something that is not that well known, I would say. People tend to think that all valuable data is inside a couple of systems inside each health institution. But I would argue that people that actually know where data comes from and where it is stored, and when they got into the institutions, they see that they exist in dozens of different systems. Of course, some of them then gets aggregated and goes to central databases, but some of the value of the data you lose when you are aggregating and summarizing and putting that information in single systems. So it is really, really an issue, interoperability and scalability. And we know that this heterogeneity that exists is not decreasing. Actually, it is increasing. And so we need to tackle it and not trust that in the future, everybody will use the same system or just one system, because that just simply will not, it's not going to happen. The third thing is transparency and compliance. And this thing about using the data for secondary use, it creates a new issue, a new problem, is that the people that want to use this information, they want to know the source and the process that this data has somehow gone through. So they want to know who has got the data initially, who has changed it, why the data was collected, when it was collected, what were the forms. So something that we typically in research call as the protocol, which is very important when we are doing research. Well, if you want to use real world data, well, you should be able to have access to something similar. So the protocol of data collection and how it was managed. So these challenges, typically today, they are all limiting somehow the potential of this data and innovation. And for instance, AI used in healthcare is much restricted because of these things. And actually, some of these things may make dangerous to use this data if we don't have data privacy and interoperability and scalability in place, and transparency and compliance, because we might not know what actually we are using to, for instance, create new AI tools that somehow then go to healthcare. So this is the problem. What we want to, so could you move to the next slide, please? Okay. So what we have created is an infrastructure that we propose to be installed inside health institutions that help to promote this zero trust data space platform. So this is a solution that protects sensitive data and intellectual property that guarantees through strong authentication and audit logs with blockchain-based auditing, and is built on GDPR and NIS2 compliance. So the idea is that health institutions install a system inside their own servers, I would say, that deals with the federated heterogeneous data sources, transform those data sources into OMOP standard, and then this system is able to receive packages of processaments of this data from outside, process the data, and then just send outside the results if the health institution agrees to. And so this somehow is promoting the federated execution of batches of analysis that can be executed in many different institutions. And the idea is that this does not, if health institutions want, they can do this analysis without being afraid of their raw data going out from each institution. So this uses open source infrastructures, and so it's very modular. It can be adapted to many different environments, and so somehow avoid also vendor lock-in in supporting these platforms. And we have been installing this in many hospitals already here in Portugal. Most of the Portuguese hospitals have already these systems, and so this somehow is helping to accelerate collaboration innovation. So it is possible today, if you want to run a package of analysis, just to deploy it to many different hospitals in Portugal, run it and have the results sent back, and you then compile the results from different health institutions without you as a researcher having access to the raw data. Okay. So I would say this is the presentation. So we feel that we are helping collaborative innovation and in AI and data science, and while still ensuring security, compliance, and auditability, because all of these processes are documented, and so it's easy for the health institutions to see how transparent these are.
Okay. Excellent, very clear. Immediately I'm thinking of, I see these things as dots that need connecting. And already I see some dots that probably Erky and Michael are thinking, okay, we maybe never need to have a talk. But this is a public session, so you can do that later on. What I'm interested in finding out, and I'll stick with you because you're still here. We've got enough time to look at a couple of questions. You mentioned, Ricardo, you're currently targeting hospitals in Portugal. Is that correct? Is that, you know, is that your current market, or are you?
Yeah, I would say that's our starting point. We are actually also working with other institutions in Europe because of this European Health Data Space initiative. They are very aligned with this.
Yeah.
But I can tell you that we have already some contacts also in the Dubai area and
Okay.
other countries there. So we are already targeting other markets, other geographically places, because this need is not just from the European data space,
Yeah.
come from there. So it triggers a little bit, but then there are other places.
Well, I think one of the things we can do, I mean, obviously yesterday we ran a session around data sharing around the globe. So we had input from Africa, from Latin America, from the US, etc. So sometimes it's important to think, yeah, the European health data space is very interesting, and it keeps a lot of people awake. Also sends a lot of people to sleep as well. But it's one of those things I think we need to think there's plenty else going on in Africa, in India, in Canada, in Latin America, in Australia. Where can I fit that same solution you've got here that's open source? Okay.
I can tell you, Andy, just let me interrupt something. For instance, in Brazil, they have been copying some of the European regulation for years, and so it's a market that is interesting.
Yeah.
I've already
and
seen
obviously there's a linguistic piece there too, and in Mozambique. So don't forget the colleagues from Mozambique too. So interesting. So that's where you are now and where you're looking to go. What's the big ambition in terms of market for you? Are you thinking outside of Dubai, and are you looking at US entry, or where's next after Dubai and Portugal and Europe, do you think?
Well, our idea is to have something, and this is very related with the system that we have created, which is very easy to install. And so we are looking also for other companies to work with that can help us distribute this easily in other places of the world. So I don't see really a limit for us, because some of the things, the core things, are very stable. And so there is not a limitation regarding the technology. I would say the limitation will be in finding the right partners to help us take this solution elsewhere. So, Andy, we are also looking for others that might be interested in being these partners, and so we can use this platform also to ask others to contact us regarding this. Yeah, I think you are muted. Sorry, Andy.
Just by way of surprise, if you need to speak to somebody who can help you within Denmark, I know just the man, Michael. So, Michael, tell us, where are you currently targeting now, and where's next? And you're on mute. It's an infection that I spread.
There we go.
Yeah,
Thanks,
wonderful.
Andy. Yeah, I mean, generally, I think what we're targeting is we're trying to help the flow of patients in any hospital, from a higher acuity, high cost ICU to lower acuities in a safe way.
In Denmark or wider?
In Denmark, in Norway, in Switzerland, in Portugal, in Spain, in Germany, in Netherlands. So we are now MDR certified. So across across Europe, and these are the first markets. And we have applied for FDA as well. So US at the end of the year. And I think the problem is the same everywhere. It's a lack of nurses, and it's a need to push towards lower acuities in a safe way, and even early discharge to home. That's a huge thing in Portugal, for example. A huge thing in Portugal is home monitoring for chronic patients. So we're looking to do the risk patients in a safer way outside of the high acuity care, home or in hospital. And that is really, driven by the lack of nurses, first of all, and the lack of time to do it properly. We saw that only 19% of unexpected deaths and cardiac arrests, only 19% of the cases, the patients had been monitored according to protocol. And that's just nothing to do with the nurses. It's the time, it's the lack of time. It's the current standard of care, which needs to really improve.
Well, the good news and the bad news is both the same, because we have a lot of hospitals on our network, and not one of them's come to me to say we've got too many nurses, couldn't take some off our hands. So you've got an open marketplace.
Very true.
But the thing I didn't hear anything at all about accessing the markets in Finland. So Erkki, okay, where are you currently targeting now? In where's your market now? Where's coming up next?
I think most of the market is coming from Finland. There's some markets coming from the other Nordic countries too, and in Europe in general. Essentially, we have clients all around the world, from the US, from all around Europe, regarding the health economic evaluation. So like the predictive modeling of cost effectiveness, because that is the thing what we usually do based on real world evidence or the clinical trial data. I think with Specior, we are aiming first to have framework agreements with all the well-being service counties in Finland. There's 20 of them, and currently I think we have agreements with 14 or 15 of them.
Wow.
So that is quite good. Then probably we are aiming Sweden, Norway, Denmark, of course. Danish authorities are not very keen to give away their data to Finland, I know. So maybe we will implement, Specior someday in Denmark, because then we could have Finnish data there. Because the Finnish data is portable outside Finland, but it requires an environment which is audited and certified based on the Finnish regulations, which are, I would say, stricter than the European health data space. And for us, I think it is quite easy from that perspective, because many of the requirements which are now in the European health data space originally come from Finnish law called as toisiolaki, which is the secondary use law of health and social care data here. It has been in place since 2017 or something. So it was partly the foundation for the European health data space. I also took part in the TEHDAS initiative, joint action towards the European health data space. All the European countries pretty much were there. So it was very good. I think the system there was very good. So it was very well done. Very well done. Sitra, which is the Finnish Innovation Fund, has been very active in that field.
We know Sitra very well. So that and their role within it, and we've been involved with as East Alliance with Sitra in some of those pieces to do with TEDAS. And I think certainly I know there's people are listening in on the chat function who are involved from not only from Finland but from other countries in that program. So just a quick question. You mentioned there about the Finnish health and care organization, because obviously that's just been as countries like to do, and I can say this because I'm based in the UK and we love to mess around with our systems. And I know in Finland, last couple of years, everything was thrown up in the air and reorganized.
Yes.
How did that, in terms of trying to get business sold, how did that affect you in terms of, okay, new feet under the desk or what?
I think for some parts it is now easier because there should be one controller of the data in the well-being service county. Because back in the day there was like Ricardo was saying, like there is a huge amount of data controllers and the data is also around different systems. So that was there. Now there should be about 20 data controllers, but that is not reality yet. There is more. And we still have the Finnish municipalities, which are sort of part of the well-being service counties, but really maybe not. They are responsible for the prevention. And that is the one thing we are sort of in Finland, which is a challenge, is that prevention does not have enough funding. I think it is like all around. In globally speaking, there's about 50 billion which is put into prevention and the treatment of disease, like putting or trying to correct a wheel that is 850 million. So 6% of the funding of healthcare is going to the healthcare. Other is treatment of sickness, pretty much. So and regarding the system here, it is pretty complicated nowadays for some of the MDR companies to have access, because it has been very burdensome for those well-being service counties to manage the new system. But I think they are getting better, much better now. And the ministry representative was saying that it is looking good now. So
okay. Finland's got a good reputation for having a service that's a wellness service as opposed to a sickness service. So even the system we've got is still pretty good, because again, unless Ricardo and Michael are going to shoot me down, I don't see Portugal or Denmark or anybody else on this call turn around and saying, "Oh, we just do prevention only. Why bother treating people? We can prevent first." There's it's a international issue that we see across our network. I'm interested in a couple of things, and I'm conscious that I'm sort of moving around here. I want to come back to a couple of things that you said, the three of you, because one of the questions we've got in the chat function that's going on away from our screens is, one of the questions is obviously you're part of 3 very successful ecosystems. I put information to the attendees about those ecosystems in our chat function, but where do you go? I mean, in terms of advice, we hear from businesses, in terms of starting up, getting access to finance, understanding the regulations. What sort of support do you get from your cluster? I'll come to you, Ricardo, first, and then Michael, and then back to Erkki. What does your health cluster Portugal do? Do they provide you with access to information, tenders, funding, etc.? Please, Ricardo.
Yeah, I would say more to the network in the Portuguese case. So I would say that most of the companies are active enough to find the tenders that are interesting.
Yeah.
Then if we need a partner, then we use our health cluster, and also if the opportunities for grants, European grants, for instance, in that case, it's very, very helpful. Another thing that in the last years it has been happening in Portugal is that some of the opportunities for grants, they are interesting if we have enough companies, universities, health institutions involved, and for this we need articulation between these institutions. And so in some cases it's the health cluster that somehow takes the lead, although many times it cannot be a part of the consortium, but it takes the responsibility to find the partners so that it makes sense. And just one last thing that I think it's also important and very innovative, at least in Portugal, is the cluster asks the different partners what should be promoted for the next 5 to 10 years. And then this is really, really interesting, because some of the things that we are now planning to apply for are things that are somehow on a roadmap that we developed all together inside the health cluster. And so we have defined like a vision of the things that should be tackled with in the next years. And this is not something, Andy, that comes from the government. It's something that comes from the people that are the companies and the health institutions and universities that are involved with the cluster. So it's more bottom up than actual top down. And so this is something that I think it's interesting and it's working well.
That's good to see, and we regularly see that level of expertise within Health Cluster Portugal, and it's a shining, and there's no accident we've come to pick on the 3 countries we picked today because of expertise like that with Joanna and Patricia and Sarah, we know from the cluster as well, but also, and this is I'm going to come to Michael, when we know about those needs that people have for project partners, we are also very much very much mindful of many of our projects, and you've seen some of them over the last 2 days. They've been presented here with colleagues like from Caro, etc., who's been running some fantastic innovation projects. They're full of our members, they're full of our ecosystems and their members, because we know and they know we've got that network, which is a research network. If you want to get in touch with universities, over 360 universities, there's 120 hospitals, there's 90 patient organizations. So it's a two-way process. And a really great example of that is over in Denmark, because Michael, I mean, just to come to you, how do you play in that sort of field with the cluster there in Copenhagen?
Yeah, we've gone over the past year from being a startup to being a scale up, because we were registered. We have an MDR certification, so suddenly it's a different ball game all of a sudden. I think what we've learned, we're getting a lot of delegation visits over to Denmark, also because it's like Finland, it's a bit of a first mover in healthcare technology. So it's great. We have delegations from all over the world, mostly Europe though. I think what we're finding now that we need from our cluster is that we need to have actually put some political pressure, because we have a system that's very innovative, our healthcare system, but where we are at the moment is that there's loads of funding for innovation, but there's no funding for implementation.
No.
And that is exactly where that's the sweet spot that we like. So actually we are involved on a political level in forming the new digital strategy of the healthcare system. And we need to spend a lot of our time getting to that influence level, because we keep seeing new innovation visits coming to Denmark delegation, and it's all about early stages and it's all about innovation in itself. But it's very often, we come from a research background, and we see it's very often for researchers by researchers, but there's a lack of connection between the research results and how to be implemented in a hospital. And a lot of our network has come from our clinical founders who are both researchers, and it's great. But a lot of these people, when you ask the researchers, so where do you see this applied in your hospital? That's a different story. It's hardly even the same hospital, right? It's not necessarily comparable. So we need to try. We spend a lot of our time trying to help form that we actually have resources, that hospital actually have resources for implementation as well, so that all of the great inventions can come into use also in the home market.
Well, innovation without adoption is wasted innovation in healthcare. Yeah, what's the point? And I say that with all relevant grumpiness. What's the point? Because it's nice to do, but what's the point? So, and I think fantastic examples there in Copenhagen. I know because I work with Odette and Jesper. I think now got stronger connections because of the network we're in. With our ecosystems in Canada, because it's about expanding those connections, whether it's with a program during health at Las Vegas, or coming along to our Mobile World Congress summit that we're going to be doing in March. It's about making those connections using existing infrastructure that's pre-built. And that's exactly, coming to you, Erkki, what Quopio are really good at. So Erkki, in the Quopio sort of sense, what's the sort of level of support in terms of the cluster there?
I would start with my common clause that I'm from the happiest place in the world. Kuopio is the happiest city in the world, and Finland is the happiest country, based on some criteria. So that is a good thing. So we are extremely happy to be here. We have members all around Finland and also abroad, from Switzerland, from Estonia, etc. And regarding Kuopio Health Cooperative, I would say it is a good thing we have actual organization. It is not only a project. We have a CEO, we have a person who is responsible for the project management. We have a person who is responsible for the communications. So with the membership at Kuopio Health or partnership, there's two models. There is a membership where you own the cooperative for part, and partnership where you don't own, but you have pretty much the same rights. You get visibility, you get communication support, you get support when you have product launch or information or a news. Then there's a lot of collaboration happening, like, between the public and private sector. So we have members from public and private side. So all the public sector organizations like Kuopio University Hospital or the biggest healthcare related university in Finland, which is the Kuopio University, is our member. Polytechnic is the member. Municipality is a member. And then we have very large companies like Pfizer, for example, as a member or a partner. And then also Ferring Pharmaceuticals, which have a huge factory now here. And then we have also very small members like startups, and they can all borrow, the experiences from each other. Then we have two very well working groups. So we have research, development, and innovation working group, which is much related to the education, innovation, implementation, stuff like that. And then we have data working group. And data working group is much related to the novel use of methods and discussion. Last time we were discussing about really deep tech IE systems. So we have meetings about 4 times each year for each of the working groups. So I would say that.
I think
And we are always happy to hear more about like successes, what we should do. We also arranged Kuopio Health Insights, where we had very high level participants last summer. So
I think with all our ecosystems that we have in our network, the idea of having regular meetings, regular programs around funding, regular support, but also regular collaboration visits, regular sessions. So I know obviously the first thing the three of you will be saying to each of you is, when can we go to Portugal, Denmark, or Finland, and try to look at that. So that's always important. The other thing about our ecosystems is every 6 weeks I bring all our ecosystem leads together with my colleagues, and we focus on 2 or 3 ecosystems at a time, because we understand the value of that network. We understand the value of funding opportunities, the value of implementation programs, the value of trade partnerships, because that's the value of that ecosystem infrastructure. Anyway, I also understand the value of time. I want to ask a couple of quick questions. I've understood what your itch was that you tried to scratch with your solution, your services, your research. I've understood the different markets you're trying. Michael, what do you need? What would help you? How can people collaborate with you? What's the best way to do it? Is it via LinkedIn or do people reach out by email? How do people collaborate with you?
Well, actually, reach out by LinkedIn or just reach out via our website, walk247.com is the best way. Yeah. Always very happy. Please go ahead then.
Do you need partners in other countries? I'm just ignoring Denmark for now.
Yeah, exactly. What we need is actually what we're doing right now is it's early adapters in a number of countries that adapt the technology and the new way of working. But what we do need in the long run is a partner for each country. So we are on the lookout for distributors, but also for the different sensor companies, because we do the software. You also need to put some hardware on. So sensor companies, and first of all, distributors who have proper, say they have clinicians, they have technicians for IT implementation. So
excellent. Okay, excellent. Ricardo, what do you need? Just briefly.
Yeah, well, I think it would be interesting for us to expand somehow our own network and to have collaborations in other countries regarding people doing research in health institutions and other pharmaceutical companies and other type of entities. We are also looking for partners, technological partners.
Excellent.
We feel that the infrastructures that we have created also opens opportunities for others to put their own products and services on top of the things that we are doing. So not just for distributing, but also to create new things on top of what we are doing. And we would also like to somehow engage experts in compliance and regulatory issues. So we also,
Okay.
because as Erkki also said, then we have things that are special, typical things of different countries and regions that,
Yeah.
well, we need to also to have these guys with us. So
There's people who say no in different countries all over the world. So don't think they're special to your country. And that's the value of our network is we've got understanding from local people on the ground of what are those people who do we need to speak to? What are the regulations? What are the loopholes we need to get through? That's the value of that the ecosystem network of ECH Alliance. Erkki, final words from you. What do you need? How can people collaborate with you best?
Of course, I'm happy to contact through LinkedIn, or you can send an email to me. Regarding the business, I would say we are looking for users for Specier. So
Yeah.
to be honest, it is really good system. So, it harvests the experience we have in Finland. We have nine systems here, and 3 are available, or 4 are available for outsiders. So that is a thing we are looking for. Of course, clients and partnerships,
Excellent.
and maybe also distributors.
Okay.
If you are happy with that. So, yeah.
So there's a challenge for the rest of the audience. In the last 10 minutes, understand this. This is but 3 of a network of over 80 ecosystems spread out across the globe. Contact me and we'll find out more. Thank you very much. Thank you to our speakers too.
Thank you.
bye, thank you.
Thank you. Bye.